What's up, VetFolio Voice? Welcome back for this episode where we're discussing one of my favorite topics, Addison's disease. This episode is sponsored by DECRA and features Dr. Andrew Bugbee, who joined me to help us all learn a little more about this elusive disease. I think what I really love about Addison's disease, besides the super interesting hormone signaling and feedback pathways, is that no matter how much I learn about it, no matter how many cases I see, there's always something more to learn about it. It can always throw you a curveball. And of course that's true for many endocrine diseases, but to me, it just seems a little bit more true for Addison's disease. In this episode, we talked about the more typical versus atypical presentations of Addison's disease and touched on how electrolytes may not always tell the whole story when it comes to aldosterone deficiency. We talked about treatment options and how it's important to make sure that our dosing and our dosing intervals are tailored to our individual patients, and I learned a couple things about common comorbidities that may throw a wrench in our already nuanced management plans. I don't want to give too much more away, so let me go ahead and introduce Dr. Bugbee and let's talk Addison's disease. Dr. Andrew Bugbee is originally from Dallas, Texas. He received both his bachelor's degree in biomedical sciences as well as his doctorate of veterinary medicine from Texas A&M University's College of Veterinary Medicine and Biomedical Sciences. He completed a small animal medicine and surgery rotating internship and an internal medicine residency at the University of Georgia, becoming a diplomate of the American College of Veterinary Internal Medicine in 2013. After residency, he was on faculty at Purdue University before returning to the University of Georgia in 2014. During his time at UGA, he co-founded and directed the UGA Veterinary Diabetes Clinic, in addition to his role as an associate clinical professor of internal medicine. In July 2023, he joined the faculty at the Texas A&M University School of Veterinary Medicine and Biomedical Sciences as an associate clinical professor of internal medicine and is developing the TAMU Veterinary Endocrinology Clinic and Research Program. Dr. Bugbee was elected to the board of the Society for Comparative Endocrinology in 2019 and is currently serving as the secretary and treasurer. He also serves as co-chair of the AHA Endocrinology Guidelines Task Force. He was great conversation, full of useful information. Let's go ahead and get into our episode. I'm joined for this episode by Dr. Andrew Bugbee, and I'm really excited because we're going to talk about Addison's, which is just something I'm enjoying talking about more and more lately as I've moved in my career and seen more and more cases. I think they're really interesting and the hormone pathways are really interesting. So excited to dive into it. Thank you for joining me.
Definitely. I'm happy to be here.
Absolutely. So I like to geek out about pathophysiology and hormone pathways and things like that. So I'm wondering if we can start there with the pathophysiology of Addison's disease.
Yeah, definitely. So we know that the adrenal gland makes a lot of important hormones that are essential for kind of our day-to-day activities. And so kind of loss of those hormones can be really dramatic for kind of our overall health. And so cortisol tends to be the one we get most worried about in veterinary medicine, since almost all Addison's cases will have a glucocorticoid deficiency. And so we know that cortisol is usually stimulated through the HPA axis. And so usually corticotropin releasing hormone is stimulated by stress or illness. Things like hypoglycemia or physical activity can kind of cause a CRH release, which then is going to stimulate ACTH release, and then that will stimulate cortisol release from the adrenal gland. Similarly, the aldosterone or major mineralocorticoid we deal with is usually mostly regulated by the RAS system, and so you're in an angiotensin-aldosterone component. And its main job, unlike cortisol, which is our stress hormone, is to kind of regulate our extracellular fluid or blood volume usually. And so kind of changes of our blood pressure or hypovolemic status could stimulate aldosterone secretion. There's also a contribution to potassium regulation, and so hyperkalemia can also stimulate aldosterone release. And then there's a mild contribution to ACTH stimulation, though it mainly is going to be focused on cortisol. And so we know with Addison's disease, the vast majority of cases are going to be usually autoimmune in origin, and so destruction of select layers of the adrenal gland. And so kind of the middle layer is the fasciculata, which is cortisol producing. And so most of the cases are going to start or be directed at the fasciculata first. And so it makes sense that cortisol is the most common deficiency we see. And then most cases will eventually also impact the outer layer, which is the glomerulosa, which is responsible for mineralocorticoid production. So with this disease process, we kind of expect that all animals will have cortisol deficiency, and then some animals at the time of diagnosis will be mineralocorticoid deficient, but vast majority of Addison's cases will eventually become aldosterone deficient if they're not at diagnosis. So I think that's kind of the quick and dirty synopsis of how we get to where we get with Addison's disease.
Yes, I love it. It seems like an algorithm to me, kind of following the hormone pathways, and I love an algorithm, so I get super excited about
That's
it.
right, yeah. All the feedback loops of endocrinology.
Yes, absolutely. So let's talk about how these patients present. We get this like textbook picture, and I feel like in school, I walked away with this like, okay, this is what an Addison's patient looks like. And then, but also this input that it's the great pretender and it can really look like anything. And in my experience, I feel like it's been that second descriptor way more than that textbook first one that they gave us. Can you go over how these patients present both in that kind of textbook manner and then maybe some of the more subtle presentations that may be a little bit harder to pick up on?
Yeah, definitely. So I think classic Addison's disease kind of historically was what's been called typical Addison's disease, which is the deficiency of both cortisol and aldosterone. It's kind of usually the one that most people teach as kind of the classic presentation. And so, anytime I am approaching a possible Addisonian case, I always ask myself, what clinical signs would I expect from cortisol deficiency, knowing that, cortisol helps us respond to stresses. It also is important for things like vascular responses to catecholamines. And so it helps us kind of increase our blood pressure if we're stressed so that we can run away from the thing we're scared of. And then it also is really important for our overall GI tract health. And so, thinking about those important homeostatic mechanisms, it makes sense that with cortisol deficiency that will have, lack of appropriate responses to stress, which may manifest as hypotension or GI signs that tend to be more chronic in nature, at least initially. Whereas aldosterone, being more of a regulator of our extracellular fluid volume, is going to be more associated with hypovolemia or PUPD and some of the classic electrolyte abnormalities that we see that could also manifest as things like lethargy or anorexia. And so I think that depending on which hormones are deficient, it could impact kind of the clinical picture, and the fact that cortisol deficiency is present in all cases and aldosterone deficiency is not present in all cases initially. Oftentimes that is the diagnostic challenge because the isolated cortisol deficiencies are usually the ones that are more chronic in nature and have the more nebulous clinical signs associated with them. And oftentimes they may start as only occurring after exposure to stress. And then kind of as things progress over time, then they may start developing more consistent clinical signs. And so kind of the classic example is the dog that gets anorexic or has diarrhea for a few days after vet visit or after people come into town. And then kind of as it progresses and they develop more consistent GI signs or clinical abnormalities at home that suggest that there's a problem. The Addisonian crisis that I think everybody kind of thinks about with Addison's disease is typically because there's an aldosterone deficiency. And so kind of hypovolemia and hypotension and really severe acidosis and things like that occur with aldosterone deficiency are usually what make the animal more sick. And so usually they're the ones that can present to you more emergently for their clinical signs. And because of some of the biochemical changes with it, it's kind of usually more of a red flag that is more obvious to clients as opposed to the isolated cortisone deficiencies that don't necessarily have a lot of those obvious clinical signs. So I think the Great Imitator is usually a determination that a lot of the clinical signs may be reflective of other disease processes besides Addison's, as well as a lot of the biochemical changes that we see could also be caused by other disease processes. And so I think this is one of the diseases in veterinary medicine that really does take effort of the clinician who's managing the case to at least have Addison's disease on their radar as a possibility in these patients. And so I think in general, it's always a good idea for any sick animal or any animal that has intermittent GI signs to at least remember to keep Addison's disease on your differential list. And, I usually say, if you aren't running, cortisol at least weekly on patients, you're probably going to be missing Addisonian patients. And so I think that they're usually cheap and easy tests to run. And so, run a lot of them so that way you can catch them. And I think the more you run, then the more likely you are to keep Addison's disease on your differential list as you start working up some of these more nebulous signs, and to not necessarily expect it to be the typical Addisonian crisis that comes in and read the textbook and looks like everything that you learned about in school, and that most of them aren't like that whenever you get out into clinical practice.
Yes, absolutely. And definitely want to echo what you're saying of, if you're not running the cortisols, then you're not going to see the Addisonian cases. I feel like when I first got out, I was really looking for that, the glucocorticoid and the mineralocorticoid deficiency, and, looking for those electrolyte abnormalities, the dehydration, things like that. And the longer I've been out, the more cases I've seen, the more I realize those exist and they're out there. But there's, like you said, also these other more nebulous cases, whether, just which hormone is deficient varies, or the degree of deficiency that we're seeing. So with that in mind, these more nebulous cases that maybe aren't that classic crash situation that we learn about, can you talk about some of the blood work findings? Because we talked about physical exam, it can vary greatly, but some of the blood work findings that maybe would make you say, let's go ahead and check a cortisol on this patient.
Yeah, definitely. And so, I think looking at, the cortisol contribution to Addison's disease development, and kind of the things that we start thinking about are, looking at your CBC initially. Anemia is very common for both typical and atypical Addison's cases. Lack of a stress leukogram is commonly found in patients that have cortisol deficiency. And so remember that the most sensitive change for a stress leukogram is lymphopenia. And then kind of the next most sensitive change is the neutrophilia. And so I think there's been a couple of studies that have looked at it now, but kind of the presence of a lymphopenia is a pretty strong indicator that most likely the animal's not cortisol deficient. But keep in mind that that's not a hard and fast rule, and that you will potentially miss cases if you just use that to exclude the disease without doing more testing. On your chemistry for cortisol deficiencies, if things are present, it may be things like hypoglycemia, usually a low albumin or a low cholesterol concentration are common. And there's a recent study that came out, I think in 2022, that kind of looked at sensitivity and specificity of a lot of the different abnormalities on the chemistry panels and CBCs from these patients. And usually the lymphocyte count, kind of what they found was a lymphocyte count greater than 1,700 was strongly associated with the presence of a cortisol deficiency. And then a low cholesterol was also strongly associated with it. And so with mineralocorticoid then contributing to the deficiency, that's whenever we start seeing the normal electrolyte abnormalities. And so the high potassium, low sodium, these patients tend to be more volume deplete. And so they may have like a pre-renal azotemia. They may have liver enzyme elevation from hypoxic injury, from being dehydrated or being anemic. And then occasionally we can see hypercalcemia, which we think is secondary to the acidosis that these patients can develop. The one interesting thing is the globulin count, because oftentimes these patients are going to have normal globulins or high globulins. It's unlikely that Addisonian patients have low globulin counts. And so I think that's kind of another nice thing to kind of look at to see if it's truly a dog with chronic GI signs. Is it a protein-losing enteropathy, or could it be Addison's disease? And if their globulin count is high, that would argue that it probably is more likely something like Addison's as opposed to a protein-losing enteropathy. But yeah, I think that, kind of the classic things we learn about are lack of a stress leukogram, which could be manifested as a lymphopenia, or lymphocytosis or eosinophilia. And then the electrolyte abnormalities and low cholesterol and low albumin on chemistry are kind of the classic findings that we would think about.
That's interesting you say that about the globulins, because as you were going through the biochemical abnormalities, I started thinking about albumin and going, okay, acute phase protein, and it's going to go down as the globulins go up. So if you have a normal globulin with a low albumin, that might cue you in, but not even necessarily from the standpoint of these globulins aren't elevated. It sounds like they absolutely can be elevated. Mm-hmm. It's more so that they're not low along with the albumin, because that was kind of my way of thinking. Is I went, well, okay, if your albumin's low, like where did it go if you don't have signs of loss? And so thinking about it with respect to the globulins of, are they both low? So you're losing it through the GI tract, through the kidney, something like that, versus are those globulins normal to elevated, really kind of pushing you in that direction to say, oh, we should check a cortisol.
Yeah, and it kind of goes back to that whole Great Imitator, name that we give to it, because all chronic GI signs, especially things like reduced appetite or intermittent vomiting, are really common. And so most of the time we're going to have primary GI disease on the top of our list for those types of things. And, if you look at a population of Addisonian patients in general, the prevalence is relatively low in veterinary medicine, but if you take that population and only look at animals that have chronic GI signs, then the prevalence of Addison's goes up pretty significantly. And so I feel like that oftentimes tends to be the most frustrating cases, is just because we get so focused on primary GI disease that it's very easy in animals that have normal electrolytes or don't have other kind of the typical changes to lose track of having Addison's as a differential for those guys. And so the globulins do help, because I think about 30% of Addisonian patients may have a hyperglobulinemia, which is nice if that occurs, because it may be a red flag to you that it's not a true protein losing enteropathy.
Absolutely. This is where blood work findings are fun with interpretation too, because you get to put the pieces of the puzzle together, and then how is that affected by the hormone pathways, and it all kind of comes together at the end.
And I didn't mention it earlier, but I think I did mention the prerenal azotemia. I think one thing that's also frustrating about it is, if you have a prerenal azotemia, these guys oftentimes can't concentrate their urine as well. So they may have insufficiently concentrated urine in the face of their azotemia, which may make you lean more towards chronic renal disease. And so I think, again, we're kind of adding in more and more things that we have on our differential list. And so, keep in mind that a lot of the times they may be azotemic with insufficient urine concentration, but once they get treated for the Addison's disease, they actually don't have underlying chronic renal disease. And so it is important to, for GI cases, liver cases, renal disease cases, to consider Addison's, because those are usually the most problematic differentials that are hard to differentiate.
That's interesting. I didn't really think about it from them not concentrating their urine, but that makes sense that it could look just like not a prerenal, but a renal azotemia.
Mm-hmm.
Would the lack of protein in the urine be potentially a sign to push you towards Addison's as opposed to chronic renal?
Potentially. I mean, I think, we oftentimes can see cases that have, low stage renal disease that don't necessarily have proteinuria associated with it.
Sure.
And so I think, potentially, but, proteinuria, isn't something we necessarily associate with Addison's disease. And so I think if they were significantly proteinuric, then sure, that may make you lean more towards primary renal disease. But yeah, sometimes too, it may be a sign that, they may not be isosthenuric at the time of presentation, but they may kind of fall into that insufficiently concentrated range where they're kind of less than 1030 and oftentimes less than 1020. And so if they do have this significant azotemia, but their USG is 1020, it kind of might be a red flag to you that there is some prerenal component to it, and it's not just true isostenuria from primary renal disease.
And this is why we call it the Great Imitator, the Great
Imitator,
because it looks like everything.
You got to think about it.
Absolutely. Absolutely. And we've been talking a lot about adding cortisols on to our testing and making sure that we're checking a cortisol level. But what about aldosterone testing?
Yeah, so kind of how I usually talk to practitioners about their approach to Addison's disease workup is that we know that all animals have a cortisol deficiency. And so I think it does make sense to screen patients with baseline cortisol if you have a concern for it, keeping in mind that a baseline cortisol less than 2 is suggestive of Addison's, but is not definitive, because the vast majority of cases that are less than 2 are not going to be Addisonian. And so if you do get a less than 2, then you need to perform your full ACTH stimulation test. And usually they'll have post-stimulated cortisol concentration less than 2, or oftentimes less than 1. And so what I usually tell people is focus on the cortisol first. But if you're doing an ACTH stimulation test, try to prove that the animal has Addison's. If you can remember to do it, save an extra purple top tube for plasma analysis of aldosterone concentrations. And that way, if you get a definitive diagnosis of Addison's based on cortisol, then you can send out probably the best indicator of their cortisol, their aldosterone concentration, because we know that electrolytes are not great reflectors of the aldosterone concentration. It is not uncommon that animals will have normal electrolytes at diagnosis, but if you actually measured an aldosterone, you would have found that they were aldosterone deficient. And so I think it kind of increases the sensitivity of you being able to detect a true deficiency of aldosterone by actually measuring the aldosterone following your ACTH stimulation. So if you have a pre and post aldosterone, great. If you only have the stimulated one, then that is fine. You should be able to interpret if they have an insufficient aldosterone response to the ACTH. But I think that, we're so trained that electrolytes are what we're going to be monitoring, that I think aldosterone kind of oftentimes gets overlooked or forgotten. And about 30% of dogs will have normal electrolytes at the time of diagnosis. And if you actually looked at aldosterone, that number would probably actually be lower. And most animals would actually have aldosterone deficiency at the time of diagnosis, even with normal electrolytes.
Huh. So not so much testing aldosterone if we have electrolyte abnormalities, because the electrolyte abnormalities, we can assume we're aldosterone deficient. We need to start DOCP in addition to our glucocorticoid therapy. But more so with these normal electrolytes, am I understanding you correctly that, maybe we run our baseline cortisol, it comes back, we're still suspicious for Addison, so we perform a full stim, and you're saying also pull a purple top, an EDTA tube, during that ACTH stim, either pre and post or just post, and send that for aldosterone testing, because even in our patients who have normal electrolytes, they may still be aldosterone deficient and benefit from DOCP.
Correct. Yeah. And I think, historically, I think that wasn't a recommendation just because we thought that electrolytes were a good marker of aldosterone concentrations, but it turns out that they're not. And so I think that it's not wrong. I don't think it'd be wrong, even if they have electrolyte abnormalities, to check an aldosterone just to confirm. Because I would think, like I said, with normal electrolytes, the reverse of that is also true, that you could have abnormal electrolytes but have a normal aldosterone concentration in response to the stimulation test. So I think that it's probably the more accurate reflection of what we should be looking at, and would better direct kind of our treatment decisions at the time of diagnosis if we were doing that. But I think more importantly, we know that even if they have normal electrolytes at diagnosis, most animals will go on to develop electrolyte abnormalities weeks to months, usually within a year of diagnosis. And so it is important to continue to monitor electrolytes if you're not going to check an aldosterone concentration, to try to catch it as early as possible to avoid some of the more crisis situations with aldosterone deficiency.
Absolutely. Absolutely. I have to say, I have not done much in the way of aldosterone testing myself in my own patients, but it's good to know. And I think you have a really good methodology there of just keep a purple top back. And then if you get your confirmation, then you can go ahead and send out this additional testing and make sure you're guiding your therapy correctly. Because I recently had that question where, it was a slam dunk Addison's presentation and a slam dunk ACTH stim, very, very low cortisol, but the electrolytes were normal. And that became the question of like, do we just do glucocorticoid therapy? And that's actually where I would love to go next is treatment and how to manage these patients. But it sounds like with him having the normal electrolytes, aldosterone testing would be a good next step for this patient.
Yeah. I mean, I think that's definitely the population that I would target it to if people are going to remember anything about aldosterone, just because that would be the ones that are at risk of going on to develop a crisis, because we usually wouldn't start mineralocorticoid supplementation unless they had electrolyte changes at the time of diagnosis. And so I think if we can start incorporating that more, you may actually be using DOCP a lot more commonly than we currently do, just using electrolytes alone.
So let's talk about that, using DOCP, because now I have questions. One is, like kind of going into a little bit more detail about glucocorticoids versus glucocorticoids plus DOCP, but also like if you have these normal electrolytes, but you have a low aldosterone, are we reducing the dose? And then I'm asking you all these questions at once, I realize, so I can break them back down. But just the other day, I had a patient come in with an extending dosing interval for DOCP, which was the first time I'd encountered that. So I have all kinds of questions about treating these patients properly.
Yeah. Well, I think, we know that all animals, the vast majority of animals, are going to need glucocorticoids for sure. And so I think, prednisone or prednisolone is usually what most people are going to use. And so we generally would start that. And then for animals that have electrolyte abnormalities at the time of diagnosis, then that's usually a clear mark that it's okay to go ahead and start DOCP supplementation as well. For the animals that have normal electrolytes, I think historically most people just started steroids and then would monitor the electrolytes and only start DOCP once they became abnormal. However, I think if you measured aldosterone and got a low concentration, then it would be reasonable to start DOCP in that patient. I think in general with DOCP, there's been a lot of research over the past several years looking at dosing and dosing intervals with it. And kind of what's come out of all of those studies has been that it looks like the label doses for DOCP, being the 2.2 mg per kg dose, oftentimes is going to contribute to over treatment of these patients. And so And it's also an expensive drug for clients to, have to keep their pet on for the rest of their life. And so people have looked at lower dose protocols. And so some of the more recent studies looked at anywhere between 1.1 to 1.5 mg per kg doses as starting doses. And they were all effective at controlling the vast majority of the dogs that were treated with those. And only a minority of dogs ended up needing dose escalation closer to the label dose. Interestingly, the younger the animal is at the time of diagnosis, usually the higher dose of DOCP the animal needed. And so I think kind of what I took away from those studies in my practice is, if I have a 3 or 4-year-old dog that's Addisonian, I probably would start at the 1.5 mg per kg dose. Whereas if it was an older animal, especially a large breed dog, then I think it would be reasonable to start at, the 1.1 dose or somewhere in between there. And then generally, with dosing, for normal monitoring of DOCP, you're usually rechecking them 14 days later. And that recheck is mainly meant to kind of evaluate the dose and make sure that it's adequate enough to control the hyperkalemia and hyponatremia. And so if they have continued hyperkalemia and hyponatremia at that 14-day recheck, that tells you the dose wasn't enough. And so you would plan to increase the dose, usually by about 10% the next time you saw the patient. And then we typically start monitoring them around 25 days after their first injection. And again, the 25-day visit is mainly to look at the duration of action of the dose that you gave them. And so if they were good at 14 days, then at 25 days, if they're still normal, then you could potentially stretch out and have them come back in 27 days and recheck electrolytes, and then 28 days and kind of see what the dosing interval is that works for them. And so kind of you have two options. If you have, even if you started them on the 2.2 mg per kg label dose, if they were controlled at 14 days and had a dosing interval that looked like it was going to be beyond 25 to 28 days, you have an option of either reducing your dose or extending your dosing interval. But you usually don't want to do both of those at the same time because you would increase the risk of having a treatment failure. And so generally, because it's expensive, a lot of people may start reducing the dose unless you've already used a low dose protocol. What I generally do is use a low dose protocol, so the 1.1 to 1.5 mg per kg on the patients for starting dose. And then if that is reasonable at 25 days, then I try to work the patient to an interval of 30 days because I feel like that's more helpful for the clients as far as staying on a consistent schedule. And so if I can get them on the low dose and a 30-day recheck schedule, then that's usually ideal for me. And so usually you can kind of pick or choose your poison first and decide if you want to work on the dose or the duration or the dosing interval. And then if you found a dose that works, then you can start extending the dosing interval and see how long you can push it, versus if you did the dosing interval first and are well controlled, then you could start reducing the dose by 10% every injection and kind of see what the lowest dose to maintain their disease is. So I think, don't be scared of trying to wean DOCP if you've documented that the dose you've been using controls the animal. And so it would be reasonable to either reduce the dose or increase the dosing interval to try to save cost over time for the client. But I think you really do need to train clients to, take it seriously and come in for those rechecks, because it's going to be hard for you as the clinician to manage them and make recommendations if they're not coming in to kind of assess those responses. I think one of the nice things, especially about Zycortal, the brand name product that's released, is that it's labeled as a subcutaneous injection. And so what I found is that oftentimes I might have the client do the first couple of injections in hospital with me and then kind of get them comfortable with being able to do it. And once we find the dose and dosing interval that works, they may be able to be trained on to give the medication at home and not necessarily come in for each injection. That doesn't negate the fact that they still need to come in intermittently for you to do, routine physical exams and lab work, but it may, cut down on the amount of visits that they have to do and may make them more compliant with the recommendations over time as well. So I think there's a lot of things that we can do to help the client as far as costs go without harming patient care and kind of also not impacting the client's schedule or budget too much long term.
Okay, so let me just clarify. If you were planning, is this something where you would have a conversation with an owner ahead of time and talk about treatment interval? And perhaps if you had someone who said, prolonging the treatment interval would be a priority for me, you would start at a higher dose closer to that 2.2 mg per kg, or do you always start between that 1.1 and 1.5 mg per kg and aim for that 30-day to begin with?
Yeah, so I usually target the 30-day. And so I feel like using the lower dose, usually it kind of works out that the duration of interval is around that 30-day mark. If you're using the higher dose, oftentimes the average response may be greatly more than 30 days. And so I think, if they've gotten several doses, as long as they're not over controlled, then it's fine to maintain that dose. And then you could potentially start expanding their dosing interval to, you don't want to do it fast. And so, you probably want to do it by a few days at a time and then figure out what's going to work for the patient. And usually you could just, be monitoring electrolytes on those time points, and kind of whenever the electrolytes start becoming close to abnormal or outside the reference range, then you kind of know what the duration is going to be for that patient. I think the most recent study that looked at it, like the average duration of response on a 2.2 mg per kg dose was like 56 days. And so obviously some animals were less than that, some animals maybe a little bit more than that. But I think the concern is that, the higher dose you use, and the more likely you are to potentially over control things at 14 days. And so you actually could get hypokalemia or hypernatremia. And we want to try to avoid those things because especially hypokalemia can be problematic for things like renal function long term. And so I think as long as they're responding well and not having big excursions outside of the reference range, then you may be able to kind of use that higher dose to extend your dosing interval.
Okay, so either way, when you're changing a dose, or a dosing interval, you probably want to be doing a midway check to make sure that see what you're getting around that 10 to 14 day mark.
Yeah, I think especially the dose. The dose is probably more important if you're changing that to do the 14-day mark to make sure that they're controlled at that point. I think if you're focused on the dosing interval, as long as they were okay at the original 14-day mark, then you usually can just check electrolytes around the time that you're trying to target the dosing interval change.
And you mentioned tapering 10% at every check. So if you start at 1.5, is that the tapering 10% at every check? And do you still taper if you start at 1.1?
Potentially you can. So, I mean, if you started at 1.5 or 1.1 and you got them back in 14 days and they were hypokalemic and hypernatremic, then I would still dose reduce the patient. I think if they were, well within reference range and not, anywhere near kind of the high or low range, depending on the electrolyte, then you may need to be a little bit more cautious just because, we're already using the lower dose that's pretty significantly low, and the 1.1 is half the, label dose. And so you don't want to be too aggressive with it. But there are some patients that may need less than the 1.1, but usually those cases are going to have the dosing interval be around 25 to 30 days. And so I think the lower the dose is, you run the risk of, not having as long of a duration of action for that patient. But yeah, I think regardless of what dose you start with, if monitoring tells you they've been over controlled, then yeah, I would dose reduce by 10% the next time.
Okay, that makes sense. And with over control, they can have some clinical signs with that as well too. Do they get like PUPD?
Yeah, so they can get PUPD and especially, if you look at the labels for both Zycortal and Percortin, they tell you to be cautious with it in heart disease patients or patients with significant renal failure, have had a history of effusions or edema, just because, if you over control them and get hypernatremia, that's going to suck more fluid into the body. And so you could have hypertension or, cardiac dysfunction or injury to the kidney from hypertension related injury. So be cautious with it in those patients, but yeah, you can get PUPD from over control, usually associated with the the sodium changes that occur.
That makes sense. Can we also talk about tapering the glucocorticoid dose? Because, we have this kind of range in our head of what a physiologic dose of pred is, but from what I understand, it can actually be quite a bit lower than that in some patients.
Yeah, definitely. I think most people have a general idea about physiologic dosing, and ends up being a lot more than what most Addisonian patients need long term. So I think we usually start higher depending on the severity of their clinical signs at diagnosis. And so I think for intermittent GI signs following stressful episodes, but is otherwise normal, I think, those patients are probably able to be started on, a higher physiologic dose and can be usually tapered more quickly. Whereas if it's these more almost everyday type clinical signs, and usually you may need to start at like an anti-inflammatory dose of pred to kind of bolster their system, and then can taper it over time. And then usually the highest doses that we would use are like the Addisonian crisis patients that usually they're on really high doses in hospital that then can get discharged and tapered after they're stabilized. But, for us, we usually teach, 0.25 per kg per day is kind of our physiologic dose of pred. And if you look at most animals over time with Addison's disease, most animals eventually can be tapered down to doses of 0.1 mg per kg or less over the course of the day. Some animals may only need it every other day. And so I think, we usually want to taper it down to the lowest dose that controls their clinical signs. And if you look at it, the longer a patient's on steroids, the more potent it seems like the effect is. And so even being on a 0.25 mg per kg per day dose for 2 years, that could end up being a lot of steroid exposure. And so the animals will oftentimes start developing cushingoid type signs as a result of that. So I think anytime you see PUPD or hair coat changes, or if they develop an alk phos elevation, that usually is an indicator that they're getting too much steroid, and that you should probably try to taper their steroid dose, because the doses that they need should be physiologic and therefore not contribute to any clinical signs or biochemical changes for that particular patient.
Absolutely. Or polyphagia and they eat 5 socks and then they need foreign body surgery.
Exactly. Yeah.
Saw that happen. That was an interesting one.
Yeah. And I think that's important too, to, mention to your question about some clinical signs from DOCP overdosing. But, in general, if you have an animal that is treated with both DOCP and prednisone, usually if they develop PUPD, it's as a result of the prednisone dose more commonly than it is the DOCP dose. And so I think in general, it's a good idea to, if you encounter PUPD, to reduce your prednisone first. And then if it persists, then potentially you may need to look at your DOCP dosing. But, I think about steroids as steroids. And if they're showing any steroid side effects, then assume it's a steroid until they prove that it's not with a dose reduction.
Sure. Absolutely. That's good advice, because I think hearing that, it would create this question of, okay, your PUPD, but why and what do I reduce? So that's good advice to say, start with your glucocorticoids and then look at your DOCP if it's still persisting despite that reduction.
Yeah.
So we've talked a lot about monitoring these patients already, but because I've asked it in 27 different questions and weaving it into our conversation, would you mind kind of summarizing the monitoring and kind of the principles we should keep in mind with these patients?
So I think and we talked a little bit about electrolyte monitoring. And so I think, for these guys, the 14-day and 25-day plus would be most important. I think for steroid monitoring, usually it's going to be clinical signs post-diagnosis and kind of tapering if there are any problems. I think one thing that we occasionally run into is that animals who appear to be treatment resistant or have treatment failures, even on appropriate therapy, I think one thing to consider is that hypothyroidism and Addison's are one of the more common comorbidities that can occur. And if they're hypothyroid, they may actually have evidence of treatment resistance for Addison's therapy. And so I think one of the first things you probably could do if you haven't already screened them for hypothyroidism is just at least, submit a thyroid panel to make sure they're not hypothyroid, because they may not respond adequately until they have their hypothyroidism treated. But I think otherwise, most animals really do well on these therapies. But the other thing that we didn't necessarily talk about was fludrocortisone, which is the other DOCP option that has a glucocorticoid component to it. I think if you look at some of the studies, it was less effective than Zycortal or Procortin at suppressing renin concentrations. And so we think in general, the other formulations of DOCP tend to be more effective than cortisone. I mean, it's a daily medication, which may be hard for, clients to get in the patient. But in general, we use a relatively low starting dose. It does have a glucocorticoid component. And so, on low doses of the medication, you may not have a problem. We generally start additional glucocorticoids on newly diagnosed patients with Florinef, but maybe able to taper off the additional glucocorticoid with time. The problem with Florinef comes whenever the animals need more and more dose escalation, because the steroid component can actually start becoming pretty significant, especially in small breed dogs. About one tablet of Florinef has about 0.25 milligram equivalent of prednisone. And so if they're on, multiple tablets per day in a 3 kg Yorkie, that could be potentially a lot of steroid. And so I think that just remember on higher doses that they may start showing some cushingoid signs, and usually in those cases, it's best to probably consider switching them to an injectable form of DOCP, and then adding on the additional steroid with the DOCP. So just keep in mind that's a reasonable option. And if clients are risk adverse to coming in for multiple injections, then Florinef is available and out there, but it does have some of the limitations or annoyances that we do have to consider. But with that medication, you would check electrolytes weekly until they're normal, and then you would just maintain that dose over time, knowing that most animals within the first 2 years of therapy do need increased doses of Florinef to control the Addison's disease.
I actually hadn't even really considered Florinef. It's just not something that has that comes to mind very often because I always think of injectable DOCP. So I'm glad that you brought that up as an option. Even if it's something where we say this might not last forever, but we can try this here in the beginning and then be aware that we may have to switch later. So we've talked about Percortin, Zycortal, and Florinef and subcutaneous and oral and different kinds of uses. Could you summarize our options for DOCP administration?
Yeah, so and kind of in my opinion, probably the injectable forms are the most reliable and probably easiest to figure out a routine monitoring schedule that's going to work more consistently. And Zycortal and Percortin are relatively similar medications, and so they have the same active ingredient in them. A lot of the differences come in some of the inactive ingredients, like the preservatives and things like that are in it. And so, I would expect that responses are relatively similar between the two, but just be aware that they're not necessarily directly interchangeable medications. And so I would generally push clients more to considering the injectable forms of DOCP. I think those situations where Florinef for me becomes more of a treatment recommendation are for like the heart failure dog that develops Addison's disease, and I'm worried about kind of the long-lasting effects of kind of the injectable medications. That sometimes Florinef may be helpful. Just if there's a problem, you can stop it and it gets out of their system relatively quickly. But I think for the most part, the issues with dose escalation and things changing or getting steroid side effects from the Florinef dose that's required, I think, end up being a little bit more complicated. And so I think if I would generally prefer to do the injectable forms of DOCP.
I think that's really helpful. And thinking about the injectable forms, Zycortal and Percortin, one's Zycortal being subcutaneous, Percortin's intramuscular, and you kind of mentioned that they're not directly interchangeable. There's definitely differences between the two of them. Let's say, for example, you had to change between the two. Maybe you had a dog who was managed with Zycortal at home and they ran out, they had to come in for an injection, and all you have is Percortin on the shelf. Is that okay to switch from one to the other?
Yeah, it's okay. I think, because the DOCP concentration is the same between both, and so it should theoretically be okay at that dose. I think the, concern may be if there's any allergic sensitivity or kind of anaphylaxis that, there may be a risk of that for a medication that they've not previously been exposed to, because there are differences in the contents of the medication that's being injected. But both DOCP formulations, as Zycortal and Percortin, are microcrystallized suspensions that will usually last for a longer period of time. And you can use both of them, sub-Q or IM. Interestingly, with Zycortal, it's definitely been shown that the sub-Q administration is kind of usually the more effective and longer lasting formulation of the medication. I think most owners also like the sub-Q aspect of it, especially if they are comfortable doing that at home. They're much more likely to be able to do a sub-Q injection than an IM injection. So I think they're relatively comfortable if you ran out of one or only had access to one for a patient that's been on another. But just be aware that because of some of the differences, there may be some chances of unexpected response that may be unrelated to the actual DOCP.
Good to know, one, what to look for, and two, that it's okay to do that, because I was literally in that situation yesterday. And we had to do that, and supposedly he's doing well today. So hopefully we're okay there. But it's good to know, because sometimes, we might be limited in our access to which formulation we have. So to know that maybe it's not ideal, let's try to, get this patient on a regular regimen, but in a pinch, know what to look for, and at least the DOCP concentration is the same.
Yeah.
What about prognosis? So this tends to be one of my favorite things to talk about with Addison's is, yay, this is something we can really manage and give them a good long-term prognosis, good quality of life. But there are certainly considerations to keep in mind. We're talking about a lot of medication administration, a lot of monitoring. And then actually, I didn't know about the hypothyroidism being a common comorbidity, and that could lead to more medication, more monitoring, things like that. So maybe it's not always like a perfectly rosy outlook when we diagnose Addison's disease. But what's your general thought on prognosis with Addison's disease?
Yeah, so I think for the most part, we would say that it's an excellent prognosis, but with proper treatment and treatment monitoring is kind of the caveat to that. And unfortunately, we don't have a lot of recent studies looking at median survival times. I think the most recent one I came across was from 1997 that had a 5-ish year median survival time past diagnosis. But interestingly, if you looked at that study, that doesn't necessarily sound great because oftentimes these animals are younger than most of the endocrine diseases that we deal with at the time of diagnosis. But most of the animals were still alive at the end of the study. And so, they didn't have a kind of a end mark for that. And then for the animals that died, like 93% of the ones that died from reasons that were unrelated to the Addison's disease. And so I think in general, we would expect that well-controlled patients who stick to therapy and monitoring can have a normal lifespan and kind of live a normal life. I think the one thing, to keep in mind is that, these animals aren't necessarily having normal stress responses. And so, you should be able to plan for that. And so what we usually tell clients is, if you have an Addisonian patient that's going to come in for a recheck, or they have a new baby, or they have, company coming into town, to make sure that we're responding to what they need and kind of giving them additional steroid doses. Usually we'll just have them double what their normal daily dose of the steroid is, just to give them an extra boost to be able to deal with the stress tolerance. I think the biggest issue I've run into with patients is the client, went out of town and they thought it was okay to, be a week late on their DOCP injection. And so I think a lot of it is client education that these are important medications that are helping to maintain the health of your animal. And so, once we find a schedule that works, it's really important that we try to stick to that schedule. Being off by a day or two is probably not a huge deal, but usually the clients that have extended periods where they have lapses in therapy are the ones that end up coming in on emergency or having issues with their control. So I think, client education and kind of repeated education, kind of doing recheck visits is really important, just to make sure they stay on target and realize how important these medications and schedule are for their pet.
Sure. So a lot of good communication and like you said, reiteration that we really need to stick to the schedule and making sure that will work with what the client has going on. So, whether that means talking about how we're going to get these medications into the animal, or, dosing schedule as far as, dosing interval and are you coming in? Are you doing it at home? Really making sure that we're having those conversations so that we can keep close tabs on these guys and make sure they're getting their medication so they can have that excellent prognosis and that great quality of life.
Yeah, that's right. Yeah. And I think, usually once you figure out the dosing protocol that works, we oftentimes talk about, getting these animals in every 6 months or so to, just keep an eye on their electrolytes and make sure things are going okay. But, usually it may be a little bit more intensive for the client initially. And I usually let them know, eventually my goal is to not have you see me monthly and to start spacing out rechecks once you figure out the dose that works for your patients. So that kind of provides a light at the end of the tunnel that the intensive initial part of the treatment protocol won't be a lifelong thing for the pet. And that usually is just a couple of times a year they may have to come in and see us.
Yes, I feel like that's the story with endocrine diseases.
That's right.
Look, just bear with me in the beginning, and then I know I'm excited to see you. You're not as excited to see me, so we're going to work on that. Well, Dr. Bugbee, this has been a great conversation. Addison's, gosh, it's such an interesting topic, and I learned so much in our conversation here, so thank you for joining me. Are there any final thoughts you want to share?
I don't think so. I think just remember to have it on your differential list and to be running a lot of cortisols in practice to make sure you capture these nebulous cases that otherwise would slip through the cracks. But I think, it was great being here and great conversation to have. I'm always happy to talk about endocrine disease.
Fantastic. Me too. We'll have to do it again sometime.
Sounds good.
Dr. Bugbee, thank you so much for joining me. I always learn so much when I talk about this disease with so many amazing internists, and this, of course, was no exception, so thank you for all of the wonderful information. A big thank you to DECRA for making this episode possible, and of course, thanks to all of you for tuning in. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcasts. It'll help other veterinary professionals like you find this and other great content we try to put out. For more episodes like this, click on the Education tab on the VetFolio website. As always, we'd love to hear your input on this talk, as well as ideas for topics you'd like to hear from us in the future. Feel free to reach out to me at dvm@vetfolio.com. You can also visit my Facebook page at Dr. Cassie DVM, and you can find me on LinkedIn. And remember, if one animal is better off because of you today, it's a great day.